This is a chest X-ray on a 58-year-old male patient. This case has several teaching points for interns, students, and junior residents. And it has a very important teaching point for senior residents at the end. The abnormality is obviously on the left. There is a complete whiteout of the left hemithorax. When you see a completely white unilateral hemithorax, you have to approach this in a specific way. The first thing you have to decide on is whether or not the midline structures are shifted towards one side or the other. If the cardiac and mediastinal structures are shifted towards the abnormality, that tells you that there is volume loss. In such case, if the mediastinum is shifted to the left side, that would be due to collapse, previous surgery, or agenesis or hypoplasia. This is not the case here. You notice that the trachea, the mediastinum, and the heart are shifted to the contralateral side, to the other side. So this is the opposite of what we just explained. That means that there is mass effect and something pushing from the left to the right. If you have contralateral shift of the midline structure, you have to think about either fluid-containing or soft tissue-containing abnormalities. Fluid pushing the mediastinum to the other side would include pleural effusion, hemothorax, empyema, or chylothorax. Abnormalities composed of soft tissue would include lung cancer, metastasis, sarcoma, and others. There is another important finding on this chest radiograph. I'll give you a moment to look at this. If you haven't seen the secondary important finding, don't worry, I'll show you that later. Let's go to the CT scan now. This is the chest CT on the same patient. On the chest CT, things are easier. You could tell that there is this large heterogeneous soft tissue abnormality. These higher density areas are consistent with enhancing soft tissue, while the internal low density areas are likely due to necrosis. With large soft tissue lesions, necrosis in the center is not surprising since the large size outgrows the blood supply. There's also this adjacent fluid loculation, which is related to a pleural effusion. Part of the pleural effusion is also seen here. Now it's clear on the CT how this large soft tissue abnormality is pushing on the heart to the other side. When such a large lesion is seen, it's sometimes difficult to decide where it originates from, which makes the differential diagnosis more complicated. If this is arising from the lung parenchyma itself, you have to think about lung cancer and large metastatic deposit to the lung. If this is arising from the pleura in the periphery, you think about pleural metastasis or fibrous tumor of the pleura. If it's arising from the chest wall, this could be metastasis to the chest wall or sarcoma, such as chondrosarcoma. Finally, this could be arising from the mediastinum and growing into the lung, such as a neurogenic tumor or other mediastinal abnormalities. So when it's large like this, the options are lung parenchyma, pleural, chest wall, and mediastinum. Now what we're going to talk about is very important for more senior levels. However, it's also useful for the juniors, so keep tuned. Before you conclude on any study with your differential diagnosis and your favorite diagnosis, you have to look at the entire examination. And here I show the lungs in lung window, concentrating on the right lung. Although difficult to show on a snapshot, I'll try to show you these areas of lucency. See these dark rounded areas such as this and this here. Now that you look, you're going to see a little bit more of these lucent areas scattered throughout the lungs. So such lucencies are consistent with emphysema, a particular type that's called centrilobular emphysema. Emphysema in general and centrilobular emphysema in particular is very common with smoking. And on further questioning, this patient was indeed a long-standing smoker. The reason this is important is because I want to highlight a very simple yet extremely important rule for senior residents. Although it almost sounds like a cliche, it is important. And the rule is, what's common is common. If you show this to anybody who's junior and tell him that this is a patient who has a lung mass and he's a smoker, the first thought would be lung cancer secondary to smoking. However, in many cases, when we show such cases in exams or rounds, senior residents tend to think differently. They forget that what's common is common, and since they know more, they try to become more fancy with the differential diagnosis. This is the problem with knowing more, the curse of knowledge. It happens to us all, but we have to remind ourselves with the basic rules. It still would be reasonable if you mention fibrous tumor of the pleura or sarcoma in your differential diagnosis. However, start with what's common. Especially if you know that this is a patient who is a smoker, or if you see emphysematous changes, you have to say that you'd favor lung cancer. And this was a pathology-proven lung carcinoma. We're not done yet. Let me show you a very important additional teaching point for everyone. This is the bone window. Trained eyes have probably seen the abnormality, but let's explain a little bit more for the junior followers. This here is a normal part of a rib. This is the inner cortex, the outer cortex, and the more lucent internal medullary cavity. As you scroll up and down, you'll see that some of the ribs are abnormal. This is normal here. However, if you continue anteriorly, you notice that the rib is lost. You lose the cortex and medulla. See how the cortex is eaten up and there is a soft tissue component that extends into the bone here. Looking at this rib, it's more subtle. This is a cortex that's intact, and then you lose the cortex. So the soft tissue abnormality is affecting multiple ribs. Such an appearance would give you a hint to the nature of the abnormality. Typically, this raises the possibility of an aggressive lesion. And when you consider aggressive lesions, you have to think about malignancies. So back to the chest X-ray. You could actually see the abnormal bones on the chest radiograph. If you notice this finding on the chest radiograph from the start, you'd shy away from fluid-containing abnormalities and go to soft tissue abnormalities. Here you see the normal part of the rib. Here you see an irregular eroded rib. The same is happening below and above. So as a teaching point, always look carefully at bones adjacent to opacities to make sure you don't miss erosions. Now let's highlight a few important teaching points from today's case. We talked about a white out hemithorax. The second thing you do when you see that is to look at the mediastinal and cardiac shift. If these structures are shifted to the ipsilateral side of the abnormality, think about volume loss such as collapse. But if you see shift to the contralateral side, think about soft tissue composed or fluid containing abnormalities. Never forget to look at bones carefully, especially adjacent to opacities, not to miss subtle erosions. On CT, large soft tissue abnormalities could arise from different locations. These include the lungs, pleura, chest wall, and mediastinum, and your differential diagnosis would depend on that categorization. Always look at the entire exam before proceeding to your conclusion. In this case, the hint of smoking was seen as emphysema. Finally, the most important point. No matter what you know, remember that what's common is common. That's it for today's case. Thanks for watching. I'd really appreciate your comments and feedback, and see you with more cases later. This is a chest X-ray on a 48-year-old female patient. And this is the lateral chest radiograph on the same patient. There is nothing striking on the frontal chest radiograph, The important finding is seen on the lateral chest X-ray. The finding on the lateral chest X-ray is not easy to see. However, seeing it is important. Once we see this finding together, I will emphasize the teaching point that I want to convey from today's case. One of the important landmarks to look at on a lateral chest radiograph is the spine. And although we claim that we look at the spine on lateral chest radiographs, sometimes we look at it very quickly without being careful. This is a relatively normal vertebral body considering the patient's age. This is the superior end plate, this is the inferior end plate. You have an intact anterior and posterior cortical margin. And there are no obvious lytic lesions which appear dark or sclerotic lesions which appear white. You could argue about minimal decrease in the disc space height with associated osteophyte formation of minimal degree, which are features denoting early degenerative spinal changes. Now compare this relatively normal vertebral body appearance to the vertebral bodies below, in particular this one and this one here. Although it's a very subtle finding, you might wonder about loss of anterior cortex here. You could argue that you're not 100% sure, especially that a vessel passes in front of the cortex and could make it difficult to see. But when you look at the vertebral body below, you see the same thing. There is relative loss of anterior cortex, and there might be lucency that is involving the body itself. Given the appearance of these two vertebral bodies, it's very reasonable to question lytic abnormalities involving the spine. Now let me tell you more about this patient. The requisition came as a chest X-ray workup for a patient known with renal cell carcinoma. Knowing that kind of information, that the patient has a malignancy that has the potential to give you lytic lesions, you have to be very suspicious. Now let's look at this sagittal CT in bone window on the same patient. As seen on the chest radiograph, you have some minimal degenerative changes as seen in the form of osteophytosis here. But more importantly, the areas that you questioned on the chest radiograph, although difficult to see there, are much easier to see here. You have a lytic or dark lesion that destroys the anterior cortex in this vertebral body. A similar lesion is seen in the vertebral body below it, and even more lesions are seen here. Compare that to intact inferior and superior end plates as well as intact anterior and posterior cortex of this vertebral body without any lucencies within. So this appearance is consistent with lytic metastatic bone lesions from renal cell carcinoma. Now, as a complementary teaching case, let's look at this different patient. This is a female patient known to have breast cancer. This is another case that you might pass as normal. But given the clinical information, you have to be very careful. In any patient, you have to look carefully at bones, and that becomes even more important if the patient is known to have a primary malignancy. Now that you're looking more carefully, you'd have to wonder about these areas of darkness, these lucent areas in the right scapula, another lucent area within the right clavicle, additional lucencies involving the left scapula here, as well as this part there. And even more questionable lucencies within the ribs, such as this area here, this L-defined darkness in this part of the first rib there. Looking more carefully, you'd question these expansile lytic areas involving the ribs, such as here, there, and there. Since we only have a supine frontal X-ray without a lateral radiograph, it's difficult to assess the spine, but you'd question something there as well. Now I'll give you another chance to look at this chest X-ray that initially looked normal to us, but has many important findings. This is the CT on the same patient showing the right infiltrative breast cancer. But let's look at the bone windows. You see all these lucent and dark areas within the bones. This is within the spine. You see similar findings within the ribs at multiple locations. These here are good examples of lytic lesions involving the ribs. You're also right in questioning scapular lytic lesions, such as this one here, Even more so, you have lytic lesions within the head of the humerus. Here's another lesion that you questioned on the chest x-ray that involves the left scapula. And the lytic lesions involving the vertebral bodies of the lower thoracic spine are seen here as well. This is a coronal CT image on the same patient seen in bone window, showing you these lytic lesions with soft tissue components extending outside of the vertebral body. Here's another lesion in the lower thoracic spine, and other lesions in the scapula where there is thinning or loss of cortex as well. So this was a case of lytic bone metastasis from breast cancer. To complete the story, this is the chest x-ray on the patient performed about 3 years ago, showing you a normal x-ray without lytic lesions. Now, the teaching point that I'm trying to convey today is extremely simple, yet extremely important. This is a point that I try to remind seniors, juniors, as well as myself of when reading chest radiographs. Although when we read chest radiographs, we claim that we're looking at bones, sometimes we don't look at them carefully enough. We have to look at every single bone very carefully. Our index of suspicion when we look at bones should be very high if we're provided with pertinent clinical information such as a primary malignancy. We all look carefully at ribs, but don't forget that the clavicle and scapula are considered hidden areas. And remember another hidden area, which is the spine, that could be better seen on a lateral chest radiograph. When looking at the spine, make sure you don't have any suspicious lucency or even sclerosis, as well as no suspicious cortical interruptions. That's it for today's case. As usual, I'd really appreciate your comments with your positive and negative constructive feedback. And if you think this account is useful or enjoyable in any way, please support it by spreading the word. You can also support the account by following us on Twitter and Instagram, as well as subscribing to the Radiology Bits channel on YouTube and also sharing our videos. Your comments and interaction on other platforms other than Snapchat are also very welcomed. That's it for today. Thanks for watching and see you with more cases later.